Hello, everyone, and good afternoon, and thank you for joining us today for our October webinar. Today's webinar is Pathways to Treatment, Overcoming Insurance and Testing Barriers, and Exploring the Intersection of Harm Reduction. So I'm really happy to have all of you in the room with us today. So for our agenda, we're going to do some welcoming and housekeeping, give you all a little insight about our Unchained Kentucky campaign, an overview of today's webinar, an introduction to today's panelists, and then our panelists will get into their amazing discussion that they have prepped for you all today. And then we'll end off with a Q&A, so you all will be able to leave your questions either in the chat box or the Q&A box that will be located at the top of your screen. And then we'll close out with some remarks. So for housekeeping purposes, today's webinar will be recorded and will be made available on the Unshamed Kentucky Facebook and YouTube pages. All attendees will be muted. Please use the Q&A button at the top of your screen to ask questions. The chat is also available for use. To adjust your view and see all speakers and panelists, click View at the top of your screen and then select Speaker or Gallery. To access closed captioning, click More, select Language and Speech, and choose Turn on Live Captions. We also have our live ASL interpreter, Kelly, in today as well. So an overview over Unshamed KY. So Unshamed Kentucky is an evidence-based behavior change intervention aimed to reduce the addiction-related stigma held by Kentuckians. The campaign is delivered by Shatterproof, a national nonprofit committed to ending the addiction crisis in the United States in close partnership with the Kentucky Opioid Response Effort, or CORE. This project is supported by CORE through the Substance Abuse and Mental Health Services Administration. So let's get into today's webinar. Today, our panelists will discuss the challenges and opportunities for individuals accessing resources and treatment. Panelists will offer insight into barriers that exist for people who use substances in accessing services, including challenges around insurance requirements and drug testing requirements. Panelists will also highlight the vital role of harm reduction in creating accessible and effective treatment options. Today's takeaways include increased understanding of the complex landscape of insurance coverage and drug testing requirements, receiving tools to rethink protocols and explore low barrier alternatives to increase access, and gaining knowledge on the intersection of harm reduction and addiction treatment and how these approaches can be integrated to improve outcomes. So let's get into today's speakers, starting off with our moderator, Billy. Billy is the program manager for 12 young people in recovery chapters in the state of Kentucky and is over 6 years in long-term recovery. In his roles at YPR, he helps make communities recovery ready and lead the implementation of YPR's Epic Life Skills curriculum at 5 treatment facilities. Billy also serves as the co-chair for the Louisville Host Committee and is a district committee member of Alcoholics Anonymous District 29. He is continuing his education to better serve his community at Northern Kentucky University and their peer support specialist program. Billy is also a CIC member of our campaign as well. So hello, Billy. Tara is a dedicated advocate and leader in the field of substance use recovery. She holds a dual master's degree from American University School of Public Health and specializing in public administration and public policy, and a bachelor's degree in public policy and pre-law from the University of Louisville. As a person in long-term recovery since 2011, Tara became the Chief Executive Officer of People Advocating Recovery in 2022. Tara is also the Vice President of the Advisory Board for the Kentucky Recovery Housing Network, supporting the regulation of recovery residences in Kentucky. Tara continues to champion recovery equity and raise awareness across the nation, leveraging her expertise to create supportive environments for individuals in recovery. We have Damon Williams. Damon began his career working in outreach and case management in the field of infectious disease, which led him to implementing and navigation of care program for individuals with co-occurring diagnoses with HIV, AIDS, substance use disorder, and mental health conditions. conditions. Damon worked for Kentucky Harm Reduction Coalition and the Louisville Recovery Center before creating Omni Resource Services to focus his efforts on providing services in the realms of outreach, organizing, and collaboration. Damon wants to impact as many people as he can and leave behind a legacy of service. And last but certainly not least, we have Gene. Gene is a native of Knox County, Kentucky, and is a lifelong resident of Appalachian, Kentucky. He began long-term recovery from substance use disorder in July 2014 and has dedicated his professional career to alleviating the region's devastation from the social and economic consequences of substance use disorder in the area. He graduated from Morehead State University with a master's in public administration in May of 2020. In June of 2021, he was appointed by Governor Andy Beshear to the Advisory Board of Recovery Ready Communities after helping start the initiative during his participation in Leadership Kentucky's Bright Class of 2020. He resides in Morehead, Kentucky with his wife, Kiera, and their two sons, Caleb and William. So will you all give a virtual round of applause to our amazing panelists today? And I am going to pass it over to Billy to start off the conversation.
All right. Thanks, Taylor. And thanks to all the panelists who've joined us today. I look forward to this what I think is a great conversation. This was kind of my brainchild. At Young People in Recovery here in Kentucky, we're working on parity laws and trying to make sure that people have got the access to treatment that they need, and making sure that people are, abiding by the rule of the land, which is to follow the parity laws and make sure that people with substance use disorder and mental health have equal access to treatment. So with that, let's just jump right into it. This first question, I'll just ask everybody, in your all's experience, what are the primary systemic barriers for people who use substance use or who have substance use disorder to access treatment or resources? Damon, I'll start with you.
I run an independent public health practice. I've turned my complete practice into public health, and we run a public health clinic. So you have the normal systemic barriers such as transportation, access to care, but you also have some cultural issues there where you have to meet the individuals where they are. They're not necessarily coming into establishments wanting treatment. We can get referrals, but the people who are in desperate need, we're having to go out and get them. So that's what I have to add to that.
Okay, Tara.
Hi, everyone. Tara Hyde. And so there are a lot of different factors that kind of go into why folks can't get access to treatment or can't get access to a bed, we'll say. Along with, some of the points that Damon just raised. With transportation, there's also like provider deserts, right? Like in a lot of different locations around Kentucky, you'll have one treatment provider who's providing, great services, right? But it's only like one model. So you only have one model for 80 miles in any direction. So, and we know that it takes individuals at minimum or an average of 6 attempts at treatment to sustain long-term recovery, right? And sometimes that means trying different methods and different methodologies. And we can't do that if we don't have access to that, right? So, and only promoting one pathway of recovery and even support system, and also model with clinical treatment or social behavioral modification, right? Like there's a lot of different models that exist, but we may only be utilizing only a small percentage of those here in the state. So, are we really able to provide long-term care when we're only looking at one specialization, especially those that are acute short-term models? So there's a lot of questions, and there can be a lot of challenges with that too, from a variety of aspects. And I'll pass it on.
All right. Gene, you got anything you want to add to this?
Yeah, sure. So I've spent most of my career in the rural settings of our state, and what I would describe as a systemic barrier for access to treatment is primarily the main safety net that we still use, especially in our rural communities, is the criminal justice system. So, that is actually the first point of interaction for a lot of folks. And then sort of building on Tara's point, it then becomes dependent on members of the judicial system having an adequate knowledge and understanding of different treatment modalities, of what is the continuum of care. And often, especially in those provider deserts, there may only be one or two options. And so, it's always seemed like a barrier to me to try and have that system be adequately educated in such a specialized niche to be able to understand that. So I think there's a lot of room for growth between the industry and the professional side of the treatment universe, and how it can better interact and support the often really good intentions of the criminal justice system in providing alternative sentencing.
Yeah, I completely agree with everything that was just said there. And just to kind of follow up question on this, you know, why is it important for us to identify and to go ahead and address these barriers?
I believe that it's important. I like what Tara said. I like what Jean said. I think that it's very important to go ahead and address these barriers because this problem is only becoming worse. If you work at the ground level, and I know Tara very well, and you work doing this work, you can see it exponentially getting worse by the day. And I think that we do need to educate our professionals, our clinicians, the individuals in our healthcare system because of comortalities and things of that nature. And I just feel as if we need to be working in collaboration and not competition. We need to be working together. We need to take methodologies and evidence based, apply them to practice, and then share them across the board.
Yeah, absolutely. Especially that collaboration piece. I mean, this pandemic we're in the middle of, it can't take just one person to do this. I mean, we've got to really work together as a team to beat this thing back. Tara, Jean, you want to follow up on that?
Absolutely. Um, I think about collaboration, and I also think about really looking at upstream like things that we can do and implement upstream rather than downstream, right? Like looking at what are we doing to support those individuals who have went into treatment, right? To support them in the long term, and then also looking at folks who have not yet initiated their recovery experience, and what are we really doing to create more dialogue around what substance use disorder looks like, around recovery, right? Because that's like a cultural narrative in our community, is that a lot of folks don't even realize, because they haven't like stepped over into that chaotic use yet, but that they are misusing, right? Like they may be using because of underlying conditions that haven't been discussed with their primary care physician, right? Like there's like so many things, so many opportunities of intervention that can be embedded into current systems that can be utilized, but we're just not utilizing because we have not collaborated. We also have not, sometimes even us as in the recovery community, like we can blame certain sectors for failures in systems, right? And that could be because systems haven't been trained. They don't know how to identify, especially like the criminal justice system, right? Like law enforcement officers and a lot of those settings. A lot of them have not been exposed to even understand or know what substance use disorder looks like and what mental health conditions can look like and be how they manifest also, right? So I just think, as a society, like we have a responsibility to really look at our well-being and not compartmentalize people in recovery or people with substance use disorders or people who are using drugs even, right? Like we're all one community. We're all Kentuckians. We're all people. Like, what are we doing to help support us as a community get better?
Yeah, and briefly, what I would add, Billy, is on the collaboration piece, again, extremely pertinent in rural communities that have fewer resources, lower capacity for expertise. It's that much more needed in those settings. And for me as an economic development specialist, in my formal work, I'm always looking at this from that economic perspective. And so, in most other areas of healthcare, you have requirements to see that someone is moving towards wellness or achieving wellness. And a lot of times, yeah, it starts with the emergency room, but then there's interventions for physical therapy and physical rehabilitation, whether it has to do with major organs or breaking a limb. And we just haven't quite achieved that with substance use disorder yet. And so, we're in this time frame right now where we have access to these major public investments in substance use disorder treatment. But we're only just now starting to, like Tara mentioned, look at the front end. Where are we at with prevention and harm reduction modalities? How are we creating access and opportunity not only to prevent future waves of problematic substance use, but individuals who are in chaotic use, how are we supporting and navigating them towards wellness? And then on the back end, how are we ensuring that these big public investments we're making right now are going to yield return for the public and for society as a whole? And I think we sort of accidentally fell into this place for quite a while now with the substance use disorder story here in Kentucky of accidentally otherizing the idea of individuals in recovery and otherizing the entire subject matter. It felt easy and convenient that, oh, here are these specialists and here is this special system and they're going to fix our loved ones and they're going to make the problem going to go away and it's going to be better. And both on the front end and the back end for the individual, it treats them as sort of this unit that is going to go to this other place with these other people. And then hopefully when they come back, they can be a part of, when in reality, they were a part of all along.
Yeah, yeah, for sure. And you know, you know, to kind of piggyback off what you were saying, Gene, about the rural areas and access to treatment. Living in Louisville, we see a big treatment desert here in the city. Once you get out past Ninth Street into the Black communities in West Louisville, I mean, there's not a whole lot of options out there. And when you look at the overdose death rates for the state, while we did see that drop, in the Black communities, it went up. And why is that? Why are we not addressing those issues out in those communities? And what more can we do to make sure that that number goes down in those communities also? So let's get into kind of the nuts and bolts of this thing and talk more along the lines of insurance and what some of the requirements are. And so, what types of insurance does a person need to access different types of treatment? For instance, let's just go ahead and start with what kind of insurance do people need to be able to go into an inpatient treatment? 30 days, 90 days, whatever that looks like.
I can start again. Most individuals, it's always going to depend on the population of the of that population that you're going to serve. I am from the West End area. I'm on ground
Mhm.
zero. Most of our candidates and our clients come in, they've got Medicaid, or we can get them connected with KY connectors and get them Medicaid. If they are disabled, then they automatically go under Medicare. If they turn 65, they go under Medicare. The rules change. Although we're credentialed to treat both types, the uh, the types of treatments that we're able to give them access to changes. So that's my biggest thing with that.
Mm.
And then the other individuals, like say for instance, Kentucky Harm Reduction, they have the insurance, right? Marketplace, they have market insurance. They're putting heavier restrictions on people with substance abuse issues and telling them what they can do, how they can do. Oh, they can access a 30-day program. They can't do a full IOP, things of that nature. We're not going into the specific needs of the individuals. And that's my issue with the insurance companies. And the insurance companies are also restricting what you can provide to the
Mhm.
client.
Yep.
They're saying that, okay, you can do a program, but where you can't do peer support on therapeutic behavior days. You can't do CSA on psychoeducation days. But how does that affect that individual client? We're not dealing with a cookie cutter system. We're dealing with human beings, and they need all the support that they can get. And so I get pushback from insurance companies all day long.
Right.
I'm just giving you the short version of it.
Yeah, I know that we could probably spend hours and hours talking about all this stuff. Gene or Terry, you want to follow up on that?
I would like to hear Jean go first because I have sort of a different lens to offer.
Sure, I'll offer up my lens, and it's far less practical than what Damon had to say, but um, there's an excellent book by a gentleman named Dr. Gabor Mott called In the Realm of Hungry Ghosts. And he goes through this really meaningful exploration of harm reduction and addiction through his experiences in Canada. And I had the opportunity to be on a panel once upon a time with a guy that ended up working at the institution he was from. But the biggest thing that came to me out of both my experience in that previous panel and that literature was we're still really at the frontier of this whole situation. And I don't think that anybody, whether from the research side or from the insurance provider side or even necessarily the medical side, really has a firm grasp of being able to look at an individual when they first come in and they're presenting with some degree of substance use disorder and come up with a truly meaningful biopsychosocial, spiritual, however many pieces of that pie you want to use, but to come up with a meaningful, concrete, longitudinal plan that truly recognizes all these different aspects of the individual and creates a pathway and a direction for them to go. Whereas, a lot of times in traditional medicine, the pathway for a broken leg or the pathway for a heart attack or the pathway for diabetes, these are things that are well understood, and there is a pathway. Like, this is the plan, we as the professionals, this is how we're going to get you back to wellness. And I just don't feel like we've quite achieved that with substance use disorders yet. And so I think that sort of perpetuates and feeds into this issue that we're on right now.
Thank you so much, Jean. That's why I wanted you to go first. um, so I've raised a lot of different questions recently, especially around as far as like the treatment, the history of treatment and the history of substance use treatment modality research in our country is still very, very young. There's not a lot of data. There's not a lot of information out there to help us to really be informed when we compare it to physical health, right? That entire industry has been around for many, many years and centuries, the practice of medicine. And we just have not invested also in a meaningful way in mental health and well-being in a holistic approach, right? Um, and so some of the questions that I've raised is like understanding sort of the framework that Jean was just alluding to when we talk about treatment, right? Like, what does that actually mean? As Jean was just alluding to also about, a broken leg, when someone comes in because they have a broken leg, right? Like, okay, so like, let's fix the broken leg. Right? Like, we want to repair if it needs surgery. You go through the checklist. Does it need surgery? Does it need to go, can it heal on its own? Like, except like, what's the plan, right? And there is something that we use, right, like ASAM, that helps us to sort of determine need in some meaningful way. But it's not a treatment plan. That just really identifies where they are, right? Like, that doesn't say these are the things that we need to identify to work to get you back into a state of quality of life, a positive quality of life movement, right? Like, how do we get from here to here? And we really haven't tested that enough, and we haven't done enough research into that to really understand what that looks like. Also, substance use and across every type of substance use is a very complex illness. It's not as simple as fixing a broken leg either, right? Just as much as someone with a broken leg who has co-occurring, other health conditions. Whereas people with substance use disorder, because it is also a criminalized illness, face additional layers of trauma, additional layers of disparity, because they haven't been able to access certain resources because of shame and stigma. Some of the reason why we're here today, right? Because we shame people and tell them that they're bad, because we just don't know any better. So a lot of those challenges sort of feed into why we have not been able to invest quality and meaningful money and dollars into really helping to support efforts that will help to change our practices. And kind of coming back to the insurance question that we were, kind of starting with, insurance in a lot of ways dictates people's treatment plan, because it covers certain things and it won't cover other things, as Damon, talked about, right? So it's really, are we providing services because those are the best and those are the things that individuals need, or is that because that's what insurance will pay for and insurance will cover? I don't know. And I'm just posing the question. I tend to ask a lot of questions. So
Yeah, and I think that I think that kind of leads into the other types of treatment that we've got on this list to talk about, kind of outpatient treatment, um, withdrawal management or detox, and then MOUD, so medication for opiate use disorder, medicated assisted treatment. Or kind of to your point, Tara, that this is kind of new, right? That we've been practicing medicine for centuries, and with substance use disorder, this is kind of relatively new. The last, I don't know, 30, 40 years, maybe a little bit longer. Um, do you think that these are the barriers, that's part of the reason, the barriers to insurance, or the insurance willing to pay for like MOUD? Because I know that there's a lot of insurance plans out there that won't cover you to use a drug to get off a drug, right? Um, so are there any types of insurance that you all know of that would allow it across the board? Or I think some my experience too is that insurance companies, even though they're getting the medical advice from the providers saying this person needs 30 days in inpatient, um a lot of times insurance comes back and says, well, we're willing to pay for 14 days of outpatient. And that's kind of what you're stuck with. So is there any way to navigate kind of around that, or are we just kind of stuck with what the insurance companies tell us to do?
I mean, the thing is, and I'm just going to jump in and then everybody else can. I'm sorry. I was already unmuted. So the thing is with the insurance company is that, or when you think about these sectors, right? You think about like the treatment industry versus physical health. Physical health, like think of a hospital, think of all the employees, all of the different departments, right? Like they have a whole department that's doing nothing but accounting and service requests and keeping up with the numbers. Or like they have a whole we don't have that in the treatment industry, right? Like we don't
Have
have
it.
whole departments that are like out there just grinding numbers, right? Because we
Oh,
don't have that
Tara,
type of investment in industry. So,
come on.
again, right? Like it all kind of goes back to like where are we investing, right? We recognize the need in physical health because it's an immediate response, right? Like it's you break a leg, it's broken, you can't walk, right? But with substance use or even mental health, right, sometimes it can take years before individuals even have symptoms that are like very visible, right? We know that mental health is definitely something that can be sort of hidden and doesn't present until later on in life. Or, people, I mean, we hide our illness and our sickness, right? So, it doesn't present right in front of people. And that a lot of time leads to some of these symptoms of, getting intervened with through incarceral settings and a lot of different things because it's criminalized too. So there's a lot of different factors there, but I'll stop talking and pass it on.
Damon, you want to add to this?
Tara does done so well. I mean,
I
a
know.
lot of us are small agencies, we can contract out billing services, things of that nature. Like my organization, I'm all about public health. Okay. But we don't have all those resources at our disposal. So, and then insurance is driving our programs. But then what do we do with the holes and the gaps? How do we go and tell our clinical team, whether it be lower level or higher level clinicians, we still need to do this work, whether or not the insurance pays for it or not? Can you take a loss? Are you willing to write this off on your taxes when I can't afford to house this individual because they're on Medicare, but if we send them back into their environment and they already got complex health issues, what do we do with them? For me, I take them and write it off as a loss. But you also have to have the passion for what you do. And I'm gonna leave you with that. Thank you, Tyra.
Well, let's get on to the next question, and unless Gene, you want to follow up with that.
Yeah, yeah.
I know you're very opinionated about this too, so jump in there.
Well, sure, and I'll try and keep it brief so we can move on. Um, something that it reminds me about is in the early chapters of Dreamland, when we talk about like how we got to the opioid crisis to begin with, a huge part of it was the desire to take the shortcut to deal with chronic pain. So, there were models to deal with chronic pain that were holistic, that involved different specialties and concrete plans. But through that temptation to take the shortcut, we eventually landed where we're at now, 25 years later, millions dead. And, y- you know, and I don't mean this in an unsympathetic way towards insurance companies and organizations. At the end of the day, our society is one that is built on businesses and the ability to make profit through innovative ideas, and that comes with good and it comes with bad. I can get any product in the world that I want. It'll be on my doorstep in 2 days. That's pretty cool. Food brought to me, all these other things. But, everything has trade-offs. And so when we're talking about insurance and we're talking about substance use disorder care, they're going to drive at the cheapest solution. And to me, the root of this issue is the insistence of looking at addressing substance use disorder on a short-term basis. When we do have good evidence and we do have good understanding that the process of recovery from substance use disorder is a long-term process, both for the physical and mental healing parts of it, as well as all of the social components. And yet we consistently and chronically only invest in and only allow payment for the short term acute care type interventions. And, it's doing the same thing over and over again and expecting a different result. And, anecdotally, that's often referred to as insanity.
Mhm.
Um, and so, that was the biggest thing I wanted to add to this piece.
Well, and thank you, and I'm glad I let you speak on that because that really moves us right into the next question. And if insurance companies are going the cheaper route for substance use disorder, then you know what about parity laws? So if somebody wants to talk to or kind of describe what parity laws are and kind of what we need to know about them. I was at the opiate symposium this past week and we were talking about it, and I was talking about how YPR is working on parity laws here in Kentucky and out in California, and I was just surprised to see how many people didn't really know what the parity laws were. So if one of you all wants to kind of jump in there and kind of educate
I'll,
the group here, have at it, Gene.
I'll jump on and I'll take first crack. So, again, same themes that have been here in this whole conversation. And for me, the theme really goes back into the otherizing concept, sort of that root of stigma. But, scaling it back out and looking at it in economic terms, you're gonna pay the price no matter what. For unaddressed mental health, for unaddressed substance use disorder, unless you are willing to out loud say and look at people and say, well, let them die. Unless you're willing to do that, you are going to pay the price. You're either going to pay it in terms of people not being engaged in the workforce and not contributing to the tax base. You're going to pay it in terms of people being incarcerated. You're going to pay in terms of it on the effect that it has on their family. And, at the next layer, you're going to pay for it in terms that has on society at large. And so it is this insistence that we seem to be stuck on in only looking at addressing this through the lens exclusively of specialized care only that is perpetuating the issue. If you want substance use disorder and mental health care treatment to be more affordable, then you have to look at it in the context that it demands for treatment. Diabetes becomes expensive when you don't teach an individual how to properly manage that disease, how to eat healthy, how to engage in exercise, and take care of their holistic health and well being, which there's growing and growing recognition that extends just as much into the social atmosphere. What is their relationship like with the community, with their family, and so on down the line? And that you're going to pay the price either way. And what we've been doing for the past several years is we've been putting that price off onto the federal government and onto insurance companies, and they're bearing it for right now. But eventually they won't be able to bear it. And that those discussions are already happening. And so when you talk about parity and you talk about care for substance use disorder and mental health issues, you have to talk about it in the longitudinal context. You have to talk about it in the whole continuum of care, which is a circle and not a line. It's prevention, harm reduction, treatment, recovery. And once we achieve recovery, how do we transition that person into becoming part of the prevention system that exists within the community? It isn't linear, it's circular, and you're not going to get the bang for buck unless you look at the whole picture, and someone's going to pay.
So yeah, and you're absolutely right there. I love the description of the circle, and that is really that's how we get to recovery, right? Um, so for me, the parity laws are basically, in a general sense, say that people with substance use disorder and mental health disorders are um, required to receive the same kind of treatment as any other medical illness. And for me, from where I'm sitting up here on my perch, I don't see that happening. Back to Tara's point about somebody breaks a leg, what kind of care do we give them? We treat the injury, right? But then we have follow-up visits. We have pain management. We go back in 6 months to evaluate to make sure that everything's good, right? Um, can somebody tell me if we do that with substance use?
Definitely don't.
Do we do it?
And that and
Yeah.
and that's true, right? Like you get physical therapy. You might get a follow-up in a year. You get all of these additional sort of perks when it comes to physical health, but we don't do that with substance use and mental health. And that's what parity does, right? It says that if an insurance plan offers one thing, you also have to offer the same comparable policy for substance use for physical health, right? Like that's the whole point, is because it want like that, because we are trying to move in a direction of wanting to support holistic health, right? And understanding that these both overlap and intersect and are a part of the individual's lived experience, and we need these things in order to be better. um, but we're still not at a place yet where that is actually being implemented, right? Like the policy exists, right? Like we have parity laws and they've been around for like 20 years, but we're still not implementing them in a way that we should. And a lot of that is because I would say, and this is a Tara Carr even opinion here, and that is because like we still have such a huge, and I hate the term stigma, I really do. Um, but it is a shame-based illness. And we still believe that substance use disorder is a moral failing and not a public health issue. We still see it as this in our legislative process, in the policies that we write, whether it's at our businesses, if it's insurance, and other spaces. And until we really, and again, like this is why PAR does so many language trainings, because the more that we really start to unify and talk about substance use disorder being a public health crisis and a public health challenge, that is an illness that can be treated with all of these different and incredible, amazing modalities that we have to offer. Until we start doing that and start speaking with that unified voice, we're going to continue to get these little small chunks of just,
Yeah.
Yes, this is great, but we're not actually seeing things implemented and seeing the systemic changes that we really, really are just mouthwatering for, right? We have to do that as advocates and as either policy analysts or people in positions of power, people at our state government, wherever you are. Like we have to start unifying and speaking in that language to get people to know and understand that it is an illness that can be treated, that and we just need to have the ability to do so.
Yeah. Yeah. Damon, would you like to add anything to this?
I think Tara summed it up well. I think Jean did an excellent job. We're going to have the resources, and we're going to have the ability on each level to bring systematic changes for effective outcomes.
Yes, absolutely. And I'll pose this question to Gene and Tara, because this is something that the three of us have kind of talked about. In order to get like recovery supports, covered under insurance, would you two mind talking a little bit about the potential of what a value-based model of care would look like?
Do you want to go first? Okay. Um,
Kind of go quickly here,
yeah,
if you
yeah,
can.
I'll go quickly. Okay, so, currently the way that we look at this, the current payment system is units of service delivered. That's also your outcome metric. Did I deliver the service? I delivered the service. I get paid for the service. We succeeded. It works great for Coca-Cola. It does not work very well for human beings. So, if we want to address this, we have to step back and we have to, look at what data is available to us and, have data-driven decision making. And YPR does it. There are some other groups that do it. There's lots of good emerging research around concepts like recovery capital and emerging information about harm reduction modalities that work and are effective because, there's all these different tiers. If prevention didn't help somebody and they fell into substance use disorder, we got to keep them alive so that we can get them to treatment. And then what? Well, we can look at the existing evidence and understand that there are supports, just like Damon talked about. We don't have to continue in a system that requires the people that are given their blood, sweat, and tears to this work on a daily basis to eat these costs. We know recovery housing is an effective intervention, an effective post-treatment modality to help individuals build social and personal capital, which results in recovery capital and allows them to stay on a pathway of recovery. RCOs are extremely effective at creating those third rail spaces where people can go where they aren't stigmatized, where they're loved and supported while they're in the harm reduction space, and they're loved and supported and celebrated when they're in the recovery space, and it keeps them engaged and it de-otherizes them. And, also, and God bless everybody who was a part of it along the way. But when SAMHSA came out and established the peer support specialist role, it was not meant to be an adjunct to clinical treatment and clinical modality. The value of the peer was the lived experience and the ability not to tell somebody how to live, but to show them how to live. And we haven't done anything to build out the peer framework to give them an actual career path or to recognize or appropriately train them in all these settings that we keep throwing them into. They're riding around with law enforcement on QRT teams and deflection programs. They're working in RCOs. They're working in hospitals and bridge programs. They're operating in recovery residences and RCOs and all these different places. But we just have this one standard training, and more often than not, they're completely, trapped in that clinical box. And so within a value-based framework, you're able to recognize the value that these different parts bring to the equation and treat the person holistically. And eventually you'll be able to calculate what that costs and make equitable payment to each part of that system across the continuum of care so that we're not always fighting for the grant or dependent on philanthropy, and we're actually building a system that's going to carry the individual into wellness. And the last thing that I'll say is, again, you're going to pay for it either way because the tax burden on the public is going to exist if mental health and substance use disorder goes unaddressed. It'll exist in the criminal justice impact, in the EMS runs, and ultimately in the fact that this person doesn't get to be a part of society, that they don't get the opportunity to have meaningful work, that they don't get the opportunity to be whoever it is that they want to be in the world. And that's the privilege that I have. I am in recovery and I get to be a part of the world and get to be the person that I want to be. But it is because I was afforded an opportunity at a system that lifted me up, and I had a bunch of other crap that was going for me anyway. So we need to extend that to other people and not just relegate them to the soft bigotry of low expectations.
Yeah. So thank you for that, Gene. Tara?
Yeah, and I just want to say, I just want to add one piece to that, and that is that value-based payment models will inspire and help to create more opportunities of collaboration. And the idea and the concept of warm handoff would then be solidified into an actual framework, right? Like people will then be able to easily move through a system of care that will then like help to support them either on their upward path from harm reduction into clinical treatment or other types of modalities, or a downward path of high level care into recovery housing, right? Like, so whatever path that looks like, right? Like that's the entire idea of the framework, is that it would then be established for a long term. It's not just looking at this one snippet of an interval that they would receive services, right? And in the recovery community and in clinical, with clinical providers and treatment industry as a whole, we always talk about longitudinal data, right? Like how do we follow care? How do we follow patient care and outcomes, right? Data. This would give us an opportunity to do that because we can then cross-pollinate, providing services with other organizations, with other agencies, and not have so many challenges and barriers to share data, right? It's a really great opportunity to do that.
We've only got a few minutes left, and there's a couple questions that I do want to get to. So, one is drug testing. So, how does drug testing requirements impact a person getting into treatment?
Well, either they do or they don't. For a lot of times, people either qualify or they don't, and I think that is sometimes policies are written a certain way because we believe at the time that is the best possible way and framework to get people where we want them to be, I think. And I don't think anything nefarious was ever, I hope anyway, right? I don't believe that. I believe that, but again, like trying to frame it a different way, I think that we forget the complexities of substance use disorder and the lived experience of individuals with substance use, especially for folks who are able to detox on a friend's couch for 2 weeks and then are still in chaotic life experience, who were not housed, who need clinical high level care, but because they can't produce a positive drug test that to them deems them unqualified for said service, I think that is problematic, right? When we use it as a mode to determine if they qualify for that treatment. And that sometimes happens, right? Because life isn't cut and dry like that, right? Like you can't just like chop it up into categories. Lives are messy,
Yeah,
especially
and
for folks that are dealing with substance use and just very complex life challenges.
yeah, and that kind of goes hand in hand with another question we probably won't get to, but people that are justice involved, right? So, say somebody gets arrested over the weekend and they don't see a judge till Wednesday of the next week, and the judge orders them treatment. Well, they might not get the treatment they need because the drugs are out of their system and they're not going to pass it, or they're not going to fail a drug test. So that's a barrier in and of itself right there. And I've heard multiple police departments have that issue with trying to get people to treatment. So I think that it is time that maybe some discussions around that need to be addressed and say, and I don't know what the answer is, but definitely look at maybe a different model of getting people into treatment, right?
Yeah.
Um, the other question that I really like to get to here, and this will probably be our last one, but it has to deal with adolescence. Um, what barriers exist for adolescents looking for treatment for their substance use disorder? And are there any pathways available? Are there any pathways available to address the barriers? Because I know some of the conversations that I've had with, insurance and treatment providers and even the state are the one word that comes back to me that really really bothers me, and to be perfectly honest, it really pisses me off, is that I keep hearing that our kids are a liability. at what point are our kids a liability that we can't get them the treatment that they need? I don't know of any facility in Kentucky, and I'm probably wrong. I'm hoping I'm wrong on this, but I don't know of a facility that will detox and treat. I know that there's some places that will detox and there's places that will treat. But, if we're going into parity laws, how are we not, how's that happening? How are our kids not getting equal treatment, right? So is there anything, what barriers are out there that you all see, and is there any ways to address these barriers?
Briefly, from my understanding of the regulatory framework that exists around adolescent treatment, there are extremely high barriers to even establishing programs and making it available. Whereas, if somebody's 14, 15, 16 years old and they commit a crime, we'll charge them as an adult, no big deal.
Mhm.
Um, but we create a, a huge level of barrier for providing treatment and care for adolescents. And again, on theme with the rest of the conversation, I, I think it's a misaligned perspective because you have an opportunity there to prevent a lot of harm and a lot of damage if good heads can get together and reprioritize that. And I also think that in the stigma space, people get really uncomfortable when we talk about kids using drugs. I started when I was 15. Average age of initiation of use, at least in Eastern Kentucky, I think is something like 12 or 13 years old. Um, and yeah, I get it. It's uncomfortable. We don't want to deal with the reality that kids are using drugs, but burying our heads in the sand is not a solution.
Yep.
Absolutely. Absolutely. And I just want to add to that really briefly. I know we only got a couple of minutes left. So from a research perspective, right? Like youth and adults, we still have not invested in robust research models for adults, much less youth and adolescents, right? So we don't really, again, we're still kind of the blind leading the blind in a lot of categories. We do have evidence based in some degree, but I think that is one hesitation that I think is another reason that we don't have a lot of different types of modalities specifically for youth and adolescents. And Jean, to your point, I was 8 years old when I started misusing substances. 8. And I think that we are missing the mark when we talk about youth substance use and not just substance use disorder, right? Like, because there are so many different factors that lead to substance use and substance use disorder. When it comes to trauma, you talk about um, um, experience it like trauma that youth experience. There's a whole framework and my mind's going blank right now. Y'all probably know it.
ACEs.
Thank you. Thank you, yes. But we have some tools in the toolbox. Why are we not deploying them? I know that the Attorney General just announced a huge campaign to do some prevention specifically around youth and young people, which is beautiful and amazing. But with that, like, what are we doing when someone does present, right? Like, there should be some case management, some care coordination, some offerings with that, right? Like operationalizing the strategies that we are deploying. Not to say one way or the other about any initiative, but just saying, putting it out there. Like these are the things that we need to be discussing.
Yep. Damon, you want to add anything real quick before we get out of here?
I would like to thank you all. I've learned a lot, from Tara and Jean. And, it's always good to have different perspectives on the work that we do. I think that that's it's needed. It's needed. So I'll leave it at that.
All right. Well, thank you, Tara, Jean, and Damon for joining me today. I think that was a great discussion, and I guess I'll just pass it back to Taylor.
So want to say again, everyone give a huge digital round of applause to our amazing speakers today. We want to thank each and every one of you for putting so much time, attention, care, and ultimately transparency into this conversation that ultimately needs to be had. And hopefully we can continue to have these conversations. So for those of you who is still in the audience, I left links earlier in the chat. I left links to our panelists and the work that they do, the amazing work that they do. So if you're interested, that is in our chat. Also, if you need a certificate or attendance, or if you want to share your feedback, which we would highly appreciate, please, Saskia left a link to that survey in the chat, so you can check that out as well. And ultimately, we're always interested in looking for new partners, individuals who are interested in sharing their story, and ultimately just making sure that we're having the conversations and making sure that we're following the right trends, following the right things, and making sure that we're leveraging the voices, themes, and topics that are ultimately the most important to Kentuckians when it comes to this space. So I also left some links in the chat for you all as well. But we want to thank each and every one of you for joining us today for our October webinar, and we hope to hear from you all soon. Have an amazing day and an amazing weekend. Thank you, everyone.
Thank you.